I'll be talking today about connected speech and syntactic impairment in primary progressive aphasia. This is my disclosure. I'm employed at University of Toronto, and the research was funded by the Canadian Institutes of Health Research. So in this talk, I'm going to start off by describing diagnosis of PPA and its variants. We've actually already heard most of this twice already today, but I will go over it again just because some people have just arrived for this session. Then I'll describe connected speech in each variant with a particular focus on syntactic production. And then I'll describe 3 studies that I was involved with where we evaluated connected speech and PPA. And finally, I'll finish with conclusions. So starting with diagnosis of PPA, I'll just start with a definition actually. So PPA, primary progressive aphasia, is a dementia in which language is the earliest and most severely affected aspect of cognitive functioning. A large international group of experts in PPA established consensus guidelines for the diagnosis, and they were published in the article that I've got the reference for here. The article is by Gorno-Tempini et al. It was published in 2011 in Neurology. To be diagnosed with PPA, a patient has to meet basic PPA criteria. So first of all, they should have insidious onset and gradual progression of language impairment. And the aphasia should, at least initially, be the most salient impairment and should be the main factor contributing to disruption of activities of daily living. So this point really is saying the aphasia is primary. And finally, diagnostic testing should suggest a neurodegenerative process. These are the inclusion criteria, but basically to meet these criteria, patients have to have a language impairment that is progressive and circumscribed. These are the exclusion criteria for diagnosis of PPA. It should not be the case that the pattern of deficits is better accounted for by another disorder, like, say, another neurodegenerative disorder or vascular disease. And also, there should not be prominent initial cognitive impairments outside the language domain. There also should not, at least initially, be a prominent behavioral disturbance involving, for example, disinhibition, compulsive behaviors, or personality change. So I've just described what's involved in making a root diagnosis of PPA, and then clinical diagnosis of the variant can occur when a case has the speech and language features that are characteristic of that variant. So now I'm going to describe those features, starting with the semantic variant. So in this variant, there are impairments in naming and impairments in single word comprehension. These are core features, and both are essential for diagnosis. You can see impairments in naming really in any of the PPA variants, but the impairment is usually more severe in the semantic variant. And then to meet diagnostic criteria for this variant, the patient also has to have at least 3 of the 4 subsidiary features, and these are spared repetition, spared speech production with respect to grammar and motor speech, impaired object knowledge, and surface dyslexia or dysgraphia. To be diagnosed with the non-fluent variant, a patient has to have at least 1 of the core features. The first is agrammatism in language production. And the term agrammatism has been used inconsistently in the literature, and this is something I'll be returning to shortly. The other core feature of the non-fluent variant is effortful halting speech with distortions and inconsistent speech sound errors. In other words, apraxia of speech. So to be diagnosed with this variant, a patient has to have either agrammatism in language production or apraxia of speech, or often they have both of these features. And then they would also have to have at least 2 of the 3 subsidiary features to meet criteria for the non-fluent variant. So these are, first of all, impaired syntactic comprehension, spared single word comprehension, and spared object knowledge. The core features of the logopenic variant are impaired single word retrieval and impaired repetition of sentences and phrases. Impairment in word retrieval can also be observed in the semantic variant, but usually the word finding impairment is more severe in the semantic variant than in the logopenic variant. And then to be diagnosed with the logopenic variant, a patient also has to have at least 3 of the 4 subsidiary features. So these are spared motor speech, absence of frank agrammatism, spared single word comprehension and object knowledge, and production of phonological errors. Based on the Gorno-Tempini et al. Criteria, these are the areas of predominant atrophy in each PPA variant. In the semantic variant, the abnormality is in the anterior temporal lobes, and it's usually greater on the left than the right, as is the case in this illustration here. In the non-fluent variant, the predominant atrophy is in the left posterior fronto-insular region, and in the logopenic variant, predominant atrophy is in the left posterior perisylvian or parietal region. So now I'm going to describe connected speech in each variant, and I'm going to focus particularly on quantitative analyses that have been published in the literature. Starting with the semantic variant, it's been shown that these patients have normal rates of syntactic errors, phonological errors, and false starts, filled pauses, and repaired sequences. On the other hand, relative to controls, they have reduced proportions of open class words, they have an increased reliance on general terms, and they use words that are higher in frequency and familiarity. As well, semantic variant patients use more pronouns and more pronouns with ambiguous reference. So all of these features arguably arise from the semantic impairment. So now focusing on syntactic skills in the semantic variant, it's been found that rates of syntactic errors are no higher than controls. But it's been found that the mean length of utterance is reduced and that speech is reduced in syntactic complexity relative to controls. Also, semantic variant patients rely on a restricted range of syntactic constructions. So altogether, this suggests that there may be a mild expressive syntactic impairment in the semantic variant. Okay, focusing now on the non-fluent variant, it's been found that relative to controls, these patients produce fewer words, they use shorter utterances, and they speak more slowly. As well, they produce more phonemic errors and more distortions. Early clinical descriptions suggested that the language impairment in the non-fluent variant parallels that seen in non-fluent stroke aphasia. So the idea is that in non-fluent PPA, the patients have got something like a progressive Broca's aphasia. Subsequent investigations have both supported and disputed this idea, but the idea that the aphasia is comparable in these distinct pathologies persists, and indeed there are clear similarities. Before I go on and describe the grammatical impairment in the non-fluent variant, it seems pertinent to give a definition of agrammatism, since this is a core feature of the variant. A large body of work based mainly upon patients with stroke aphasia has identified the main features of agrammatism in spoken language. So first of all, there's a tendency to omit and or substitute grammatical morphemes, and this leads to syntactic errors. As well, there are reductions in syntactic complexity, in proportion of verbs, and in proportion of closed class words. Although agrammatism, as I've just described it, is an established concept in aphasiology, the term is also sometimes used more loosely to mean any type of grammatical impairment. So I'm going to use the term frank agrammatism to refer to the grammatical impairment that I've just described here. Okay, so now focusing on syntactic skills in non-fluent PPA patients. Findings have shown that these patients produce fewer complex grammatical structures than controls, they produce fewer well-formed sentences, and they make more grammatical errors. But in some reports, the presence of grammatical errors is a requirement for the diagnosis of the non-fluent variant, so then it's inevitable that these patients will be found to produce more grammatical errors than controls. In contrast, some studies have found normal rates of grammatical errors in non-fluent PPA patients, or they've found that these errors are made only by a minority of patients. Although frank agrammatism of the type seen in Broca's aphasia occurs in the non-fluent variant, there are findings suggesting that it's not universal. Group studies have shown, for example, that the speech of patients with the non-fluent variant may include normal proportions of verbs and normal proportions of closed class words. So these are findings which you would not expect in frank agrammatism. Other studies, of course, have found contradictory results. Wilson et al. Found that their group of non-fluent PPA patients produced reduced proportions of verbs and reduced proportions of closed class words, but they noted that this significant group effect was actually driven by a minority of patients, and that most of their non-fluent patients produced normal proportions of verbs and closed class words. So, this review of the literature shows that features of frank agrammatism are inconsistently documented in group studies of non-fluent PPA. When features of agrammatism are documented, there may be individuals whose results do not follow the group pattern. So all of this suggests that across patients, there's a high degree of variability in grammatical skills. Turning now to the logopenic variant, because this variant was identified more recently than the other variants, there are fewer studies which characterize speech in this variant, but there are still some. So overall, quantitative analyses have shown that the speech of logopenic patients shows numerous signs of disfluency. So their speech rate is lower than controls, and logopenic patients make a high rate of pauses. They also make a lot of false starts and hesitations and make a lot of filled pauses. And finally, they have an increased number of repaired sequences. The speech of logopenic patients also shows signs of word-finding impairment. So I mentioned that they have an increased pausing rate. The pauses have been found to occur especially before nouns. And also, logopenic patients use an increased number of pronouns and a reduced proportion of open class words. At the single word level, phonological errors are made by some patients, but speech is usually well articulated and with no distortions. Focusing now on syntactic production in the logopenic variant, studies have shown that these patients have a reduced mean length of utterance relative to controls, and also that the proportion of grammatical sentences is lower than controls. It has been found, though, that logopenic patients produce a higher proportion of grammatical sentences than the non-fluent variant patients. Also in logopenic patients, it's been found that they make an increased rate of syntactic errors. This was found by Wilson et al., but they attributed this to the constant rewordings that these patients do. So all of this leads to the question, is there a syntactic impairment in production in the logopenic variant? And I think across the literature, different people would give different answers to this question. So Teichmann et al. Concluded that yes, there is a syntactic impairment, but that it's mild and occurs in a minority of patients. On the other hand, Thompson et al. Concluded that no, there's not a syntactic impairment in logopenic PPA, but it's worth noting that part of the way they diagnosed the logopenic variant was that patients had to pass a syntactic production test. Okay, the studies that I've referred to so far have all used manual counts of features from transcriptions of speech in PPA patients. I'm going to tell you now about a study that colleagues and I did where we did automated analyses of connected speech in PPA. In this study, we used software to analyze transcriptions of speech samples. And using this method, we were able to analyze a larger range of features than have been addressed in many other studies. The task that we used to generate the narrative speech was recounting of the Cinderella story. The participants were 10 people with semantic variant and 14 people with non-fluent variant PPA, and there were 16 controls. We didn't have enough logopenic patients to include them in the group analysis. Using computational techniques, syntactic and semantic features were automatically extracted from transcriptions of narrative speech. So this slide and the next slide give you some examples of the automatically extracted features. There were 12 part-of-speech features, so we had counts of number of nouns, verbs, adjectives, and pronouns, for example. The part-of-speech tagging was done automatically by computer, but we also had a human annotator perform the part-of-speech tagging for about a quarter of the narratives, and we found that the agreement between the human annotator and the computer annotation was about 90%. The automatically extracted features also included 26 complexity features, for example, mean length of sentence and mean length of clause, and also there were counts of the number of coordinate conjunctions. There were 5 fluency features. These included word length in terms of number of letters, and also the total number of words produced in the narratives, as well as speech rate in words per minute, and production of fillers like and And finally, there were 11 psycholinguistic features. So these included frequency, familiarity, and age of acquisition for the words produced, and then this was also analyzed specifically just for the nouns and just for the verbs. And we also had counts of light verbs and heavy verbs. We used partial least squares analysis to identify the features that best predicted group membership. And the features on this slide all distinguished well between the semantic variant patients and controls. So focusing on the left-hand box, the things that were elevated in the semantic variant patients were, first of all, frequency and familiarity. So they used words that overall were higher in frequency and familiarity. And this was especially true of nouns. So it was a separate finding that they also used nouns that were higher in frequency and familiarity than controls. The semantic variant patients used a higher number of demonstratives than controls, and the demonstratives were words like these, those, this, that, here, there. This is consistent with other findings in the literature suggesting that semantic variant patients use less specific words, but we think that this is the first time this has been specifically examined. The semantic variant patients also produced more clauses than the controls. And yet, if you look on the right-hand box, the clauses were overall of shorter length. The explanation for this is not entirely clear, but we think it might be due to the fact that the patients had a tendency to produce a lot of fillers, like, you know, and what do you call it, and these are relatively short clauses, which also increase the count for the number of clauses. Now, focusing on the right-hand side of the slide, the things that were reduced in semantic variant PPA, they produced overall proportionally fewer nouns than the controls did, and also the noun-to-verb ratio was lower in the patients. This difficulty with production of nouns is an expected finding. But unexpectedly, we found that the patients with semantic variant PPA used words that were shorter in length than the words used by the controls. The effect was small, but it was significant. We attribute this to availability of words rather than difficulty with pronouncing words, because the controls were more likely to use longer words like Cinderella and beautiful. They use these words more often than the patients, and this may explain the finding. But overall, the features that distinguished the semantic variant patients and controls can largely be attributed to the semantic memory impairment in the semantic variant patients. This slide shows the features that best distinguished the non-fluent PPA patients and controls. So the non-fluent patients used words that were higher in frequency overall than the words used by controls, but this was as a separate finding. We found that the non-fluent patients used verbs that were higher in frequency than the verbs used by controls. I just wanted to mention that this finding is not due to excessive reliance on light verbs like be, do, be, do, go, etc., all of which are very high frequency words. But we analyzed this and found that there was no difference between the non-fluent patients and controls with respect to proportion of light verbs. And also it's worth noting that the non-fluent patients produced nouns and verbs, in normal proportions because the groups didn't differ on noun-verb ratio. Turning now to the things that were reduced in the non-fluent variant relative to controls. The controls, not surprisingly, had the non-fluent patients had a lower speech rate than the controls. And this has been documented in many other studies. In our study, the lower speech rate was the feature that best distinguished the non-fluent patients from controls. We also found that the non-fluent patients overall used shorter words than controls. This fits with findings from earlier studies that show that increased word length has a negative effect on naming and reading and repetition in non-fluent PPA patients. So just to summarize the findings, relative to controls, the semantic variant and non-fluent PPA patients used words that were higher in frequency, especially nouns for the semantic patients and verbs for the non-fluent patients. Relative to controls, the semantic variant patients used words which were higher in familiarity, especially nouns, and they produced fewer nouns but more demonstratives. The non-fluent patients had slower speech than controls and used shorter words. Surprisingly, none of the grammatical features distinguished the non-fluent PPA patients from the controls. And these features included measures like sentence length, clauses per sentence, and other metrics of syntactic complexity. So now I'm going to go on and tell you about another study where we evaluated specifically agrammatism in the non-fluent variant. There are at least two potential reasons for the variability in grammatical skills that's seen in the literature on non-fluent PPA, as I've just highlighted. So it could be, first of all, that studies legitimately include variable numbers of patients whose disfluency arises at least partially or even primarily from a motor speech impairment. Some researchers separate patients whose non-fluent progressive aphasia is associated primarily with a grammatical or primarily with a motor speech impairment, but others do not. The other potential reason for this variability in findings with respect to grammatical skills is that it could arise from difficulty with distinguishing the non-fluent and logopenic variants. So this can happen in two ways. First of all, it could be that logopenic patients have been inadvertently included in groups of non-fluent PPA patients. And then this would make the non-fluent group seem less grammatically impaired. The inclusion of logopenic patients in non-fluent groups is particularly an issue for studies published prior to 2011 when the diagnostic criteria for the logopenic variant were first published. So the flip side of this is that it could be that patients with non-fluent PPA are classified as logopenic because they don't have frank agrammatism. And indeed, some people in the literature say that they have a policy of doing this. This would then mean that the patients classified as non-fluent, the ones that are still left in the non-fluent group, would be more grammatically impaired. We tried to address both of these issues in the study I'm about to tell you about. So we addressed the issue about variable numbers of patients with a motor speech impairment by doing a thorough evaluation of motor speech skills in our PPA patients. And then in this way, we were able to look at grammatical production in a set of patients for whom motor speech impairment has been ruled out as a contributing cause of the disfluency. We addressed the issue about distinguishing non-fluent and logopenic PPA patients by using volumetric MRI data to provide unbiased imaging support for the diagnosis. And then in this way, we were able to look at grammatical production in a set of patients for whom the clinical diagnosis of the non-fluent variant is unequivocally imaging supported. So now I'll go over the specifics of the study. So the study was motivated by the inconsistent results in the literature with respect to grammatical skills in the non-fluent variant. We aimed to examine syntactic production in non-fluent PPA patients who had both preserved motor speech skills and whose diagnosis was independently supported by volumetric MRI data. The participants were 14 patients with non-fluent variant and 14 semantic variant PPA patients, and there were 4 logopenic variant patients. Blinded expert raters evaluated speech samples for features of agrammatism and apraxia of speech. The raters were blinded to the variant of PPA that a patient had been diagnosed with, and this was the reason that we included patients with all 3 variants in this study, although the study is primarily about the non-fluent patients. So the raters were blinded, as I say, to the diagnosis of each individual patient, but they also didn't know how many patients there were of each type. There were 2 raters. They're both speech-language pathologists. They rated the recordings that they listened to or watched separately, and the agreement between them was high. So they watched video recordings of narratives, and the narratives comprised topic-directed interviews. These are interviews in which patients are asked to describe a standard series of topics, including, for example, they're asked, tell me about what you do each day, tell me about your family, tell me about your health right now. The raters also listened to audio recordings of tasks that are known to be sensitive to apraxia of speech. So these tasks were repetition of words of increasing length, repetition of polysyllabic words and phrases 3 times, and rapid repetition of pataka. The raters used checklists to look for features of agrammatism and features of apraxia of speech. This slide gives some example features from the agrammatism checklist. So these features included lack of functors or closed class words, omission or substitution of inflectional affixes, and sentences that are generally simple and incomplete, and limited variety of sentence structure. This slide gives some example features from the apraxia of speech checklist. So the raters looked for syllable segregation, phonemic anticipatory, perseverative, or transposition errors, intrusion of schwa, and articulatory groping. So volumetric MRI data were analyzed in this effort to provide independent support for the clinical diagnosis of the variant. We analyzed regions of interest, all of which were on the left side of the brain, and specifically we analyzed regions that are expected to be atrophic in any variant of PPA. Atrophy scores were calculated for each individual for each brain region, and these atrophy scores took account of variation in brain or head size. This slide shows the criteria that we used to decide whether there was imaging-supported diagnosis of the non-fluent variant. So atrophy scores had to be both abnormal in the insula and or inferior frontal regions, which is what you would expect in non-fluent PPA, and atrophy scores had to be normal in the inferior parietal and posterior temporal regions. The idea with the second criterion is that it would rule out the possibility that any patients in the non-fluent group may have had the logopenic variant. This is actually quite a stringent criterion because if you look in the literature, you see that many non-fluent PPA patients have had spread of their pathology more posteriorly into the inferior parietal and posterior temporal regions. Okay, so turning to the results, I'm going to just focus on the non-fluent patients. So 3 of them were found to have frank agrammatism and apraxia of speech, and 1 of them had apraxia of speech only. 10 of the patients had no frank agrammatism or apraxia of speech. For 5 of these patients, the volumetric imaging data unequivocally supported the diagnosis of the non-fluent variant. So it seems unlikely that these patients had logopenic PPA, even though they had no frank agrammatism or apraxia of speech. For a further 5 patients, they're in the bottom right of this slide, these patients showed the same clinical syndrome and they had left inferior frontal atrophy. But in these cases, there were abnormal atrophy scores in the left posterior temporal and/or inferior parietal regions. So although this is not necessarily incompatible with the diagnosis of the non-fluent variant, it didn't allow us to rule out the possibility based on imaging that these patients had the logopenic variant. So you may be wondering what speech is like in these patients who are non-fluent but without frank agrammatism. This is a transcription of a patient who was judged by our raters not to have frank agrammatism or apraxia of speech. The patient is responding to the request to tell me about what you do each day, and this transcription is only part of their response. I'll read the response. I can't reenact the disfluency, but you'll at least be able to see the grammatical structure of the speech. So the patient said, I read a lot, and I look at television here and there, and then I do go out. I don't do very much, really. I go visiting and have an odd person in to have a cup of tea, and then on the weekends, I go out with my family. The diagnostic criteria published by Gorno-Tempini et al. Do acknowledge that lack of frank agrammatism or apraxia of speech can arise in the non-fluent variant, at least in the early stages. And so therefore we looked at symptom duration in our patients, the ones who had neither frank agrammatism nor apraxia of speech. So we found that the mean symptom duration was 3.5 years, but 3 of the patients had a history that was longer than 4 years. In fact, for 2 of them, it was just over 6 years. So it seems that some of these patients were beyond the earliest stages of illness. The main finding from this study is that some of the non-fluent PPA patients had a clearly imaging-supported diagnosis, but did not have frank agrammatism in speech or apraxia of speech. The implications of this study are, first of all, for differentiation of the non-fluent and logopenic variants. Some researchers classify as logopenic patients whose speech is non-fluent but without frank agrammatism or apraxia of speech. The present results suggest that this would lead to misclassification in some cases. We also noted that agrammatism in production in the non-fluent variant may be difficult to detect because in some patients it may be subtle, and this can be the case even beyond the earliest stages of illness. Okay, so now I'm going to just briefly describe a study that I did done prior to the other 2, but this study focused on agrammatism in spoken versus written production in the non-fluent variant. In this study, there were 14 non-fluent PPA patients and 11 controls. The study was done prior to the publication of the current diagnostic criteria. This study was published in 2004. So I've looked retrospectively at the information I have on these 14 non-fluent PPA patients. And I think there's evidence that at least 12 of them are unlikely to have had the logopenic variant. So 9 of them had imaging with MRI and or PET, which showed that the predominant abnormality was in the left frontoinsular region. And 4 of these 12 patients developed corticobasal syndrome, which is something that's much more closely associated with non-fluent PPA than with the logopenic variant. For the remaining 2 patients in the non-fluent group, I just didn't have enough information to be able to distinguish whether they had the non-fluent or PPA variants. There was nothing to indicate that, whether they had the non-fluent or logopenic variants. There was nothing to indicate particularly that they were logopenic, but I just didn't have enough evidence to address this. In this study, we analyzed written and spoken descriptions of the cookie theft picture. So I'm not going to go into too much detail about all of the results, but I just wanted to highlight a couple of things. So first of all, the non-fluent PPA patients had normal noun-verb ratios and normal content-to-function word ratios and normal rates of syntactic errors. So they didn't exhibit features of frank agrammatism. One thing I wanted to highlight is this is an entirely different set of patients. There's no overlap with the patients in the studies I just described, and these patients also are diagnosed by a different set of neurologists. We also found, we had findings with respect to written picture description. So we had the same results that overall the groups produced, the non-fluent group produced normal noun-verb ratios and normal content-to-function word ratios, but the patients produced more syntactic errors than controls in the written picture description. So basically we found that some patients make syntactic errors in written production when they don't make them in spoken production. So once again, in another study, the results suggest that some non-fluent PPA patients don't have frank agrammatism. We also found that agrammatism may be apparent in writing before it's noticeable in spoken language. So I'm going to now just finish with one slide that's got some final comments, and then I'll finish with conclusions. Now, because I've noted that there's variation in the literature with respect to how PPA patients are subtyped, it seems that we need better ways to systematically evaluate grammatical production. So most of us evaluate grammatical production by listening very carefully to patient speech. And I'm certainly not saying that we shouldn't do that, but I looked for some more systematic methods of evaluating grammatical production. So I've identified some assessments in the literature that may be useful. So first of all, there's the Make a Sentence test, which is by Billet et al. And in their publication in Aphasiology, they've included all of the stimuli for this test. So in this test, a patient is shown written words. So for example, Emma, bake, pie, party. And then the patient has to produce a spoken sentence and inflect the words. So then the correct answer here would be Emma baked a pie for the party. Results from analyses done by Billet et al. Showed that performance on their Make a Sentence test was strongly correlated with measures of patient spontaneous speech, especially production of grammatical errors and abandoned utterances. Billet et al. Compared performance on their test with performance on the Northwestern Anagram test, which is by Weintraub et al. So that's another test in which patients have to make sentences, but they just have to arrange words to make a sentence. They don't have to speak the sentences in that test. Billet et al. Found that their Make a Sentence test was less prone to ceiling effects and therefore was better at picking up subtle early deficits. There are also 2 rating scales that have been developed specifically to evaluate language impairments in primary progressive aphasia, and both of these scales provide ratings for severity of impairment in grammatical production and morphology. So now just finishing with conclusions. In the semantic variant, there's evidence that grammatical production is simplified, although without errors. In the non-fluent variant, there's a high degree of variability across patients with respect to grammatical skills, And in the logopenic variant, some patients may exhibit grammatical dysfunction, but the impairment is usually mild and occurs in a minority of patients. Further research is required to clarify the differences in connected speech of patients with the logopenic variant in comparison with patients who have the non-fluent variant, but without frank agrammatism or apraxia of speech. And I want to acknowledge the contribution of my collaborators on the studies that I've just described. Thank you for listening, and I'd be happy to take questions.
Hi, Alyssa Lanzi from Duquesne University. I was just wondering how a patient's cognitive decline can affect their discourse measures that you've seen in your research.
Well, of course, for the PPA patients, they, at least initially, their cognitive decline should be just in language. So really, I've just described what happens with a decline in language. There are other studies that look at connected speech in Alzheimer's, for example, and as I recall, those studies show that their speech is lower in proportion of verbs and syntactically simpler. So there are some similarities with the results I've described from PPA patients.
I just would follow up. I think Alyssa's question is a good one because perhaps we could turn it around and say, do you think in the language domain there are some early indicators that widespread cognitive decline is about to or is beginning to happen?
So that's a good question, and I think some of the indicators are, so I'm not basing this on data, more so on having done these analyses and being familiar with their speech, but I think some of the indicators that there's incipient or beginning cognitive decline beyond language is that the patients don't follow the instructions as well, so they don't stay on the topic. They have a lot more comments that are off topic, like, they, on the cookie theft picture, I don't know, they say, oh, I like cookies, or, things that are just kind of irrelevant, but, so they seem to talk off topic more. Also, of course, the word finding difficulty gets worse too, and that certainly affects speech, I think, really in any of the variants.
I've been wanting to ask someone like you this for a couple of days because I've now listened to about 6 hours on primary progressive aphasia. One of the, well, we won't say it's a core symptom, but a prevalent symptom language problem in aphasia with stroke is perseveration. And I haven't heard anybody talk about perseveration in primary progressive aphasia. In looking, in what you showed today, of course, wouldn't tease that out, but you've looked at a heck of a lot of cookie thefts and so forth. Can you make any observations on that?
So it's an interesting question, and I've certainly seen perseveration, but I feel like when it gets, there are a minority of patients that do this, and but sometimes it can be really severe. I think back to a patient that I used to see who had semantic variant, who was very anomic, and as her language impairment progressed, the number of words that she could use became very reduced because she was so overtaken by perseveration. So she was, and occasionally, the words that she was perseverating on would change. But, I remember at, a couple of sessions, almost the only thing she could say was sugar. And every time she, went to try to name something, she'd say sugar, no, not sugar, and then she just couldn't seem to stop herself from saying sugar. And she even perseverated in writing, so we'd be doing, spelling of words to dictation, and she would perseverate on letters. But I feel like this strong perseveration comes more when the patients either are getting other frontal impairments or at least later in the course of the illness.
That's a great question. It'd be great to be able to capture that in perhaps some imaging at some point to know where that perseveration spot is. Okay, who else has a question? Yeah.
No, yeah, nobody's ever found the perseveration spot. So I'm not sure if you'll find it's just frontal, because we see perseveration, and there are several studies that have looked at it through all types of aphasia caused by stroke with different lesion locations. So I'm surprised nobody has looked at perseveration and primary progressive aphasia.
Do you know, though,
and different types.
it's hard to look at perseveration. So I've actually given some thought to this years ago, actually, not recently. But, with some of the patients that I have seen that did a lot of perseveration. And it's a hard thing to measure because it's, it's inconsistent, different things set it off. They do it sometimes and not others. And it was just, I couldn't really come up with a good study that was really going to evaluate perseveration, but I think it's a really interesting thing. I wish we understood it better.
Thank you. Were there any medication implications regarding your clients?
Did you say medication implications?
Yes, side effects or anything like that?
So most of our patients are not being treated. So they're just because there's no cure for progressive aphasia. So some of them are on various medications, but it's actually something that we deliberately adopted a policy of ignoring, or at least we can't control for this in our research. It's not so much that we ignore it, but we can't control for this because certainly for the research that we're doing, we can't ask people to abstain from medications. It would be unethical. So for us, it may be creating noise in our data, but it's just something we have to tolerate.
Something I found fascinating is you see all this MLU reduction in patients with progressive aphasia, but when it comes, in terms of eliciting a response, but when it comes to echolalia, the syntax is perfectly intact.
Yeah.
And I find that fascinating.
It is surprising. I guess everybody heard, so the idea is in echolalia, why it's surprising the syntax is completely intact. And it's surprising to me, too, with some of the more severe non-fluent patients that I've seen who are still producing syntactically correct utterances. It's amazing how this holds up. Obviously, some people are agrammatic, right from early on in the illness, but some of them, even the people without motor speech impairment, are still able to produce syntactically correct utterances, even when they've had the disease for a while and their speech is pretty non-fluent.
Well, please join me in thanking Dr. Graham.